Hello, everybody. Good afternoon. My name is Samahir Elbkheet, and I am from Sudan. I came all the way here to present, and I'm so honored. I'm really so honored to present in front of you, Mr. Mulligan. And actually, I was preparing for this for a long time, and I was coming, and my mom was coming with me. And then suddenly she passed away. So now I'm doing this for her. Like, I'm totally here for my mom. I'm doing it for her. Thank you. Okay, I did my thesis. I'm a master's degree holder from India. I did my thesis on Mr. Mulligan Mobilization versus stretching on the treatment of the piriformis muscle. So just let's take a look in the beginning. What is piriformis? Just a refreshment. What is piriformis muscle? And what do we mean by piriformis syndrome? So the piriformis muscle is the muscles that originated from the anterior pelvic surface, from the sacral, the second, the third, and the fourth. And it goes laterally to get inserted in the greater trochanter of the femur. The main action of this muscle, as from the origin to the insertion, when the muscle contracts, it causes the lateral rotation of the hip. Right? So what is the relationship of the piriformis muscle to the sciatic nerve? The sciatic nerve sometimes comes beneath the piriformis muscle, and some other individuals, they come in front. And in some cases, they pierce through. It enters the muscle itself, dividing it into two branches. So when we say there is a piriformis syndrome, that means these muscles, it got shortening, or there is this spasm happening, or the muscle got tightens because of a lot of reasons, like sitting for a long period of time, incorrect posture, and all, or direct trauma, micro or macro trauma, direct to the muscle. So when we say there is piriformis muscle syndrome, that means the muscle went for shortening. And when this muscle goes for shortening, it presses on the sciatic nerves that's coming beneath it, right? So it irritates the sciatic nerves, and then it develops all the symptoms of that. The pain, there will be severe pain, there will be radiating pain, there will be numbness, tingling, and the heaviness. So all the neurological symptoms, that's coming from the sciatic. There's different type. There is unilateral and bilateral. This is the bilateral piriformis muscle. And we also have the unilateral piriformis muscle. So to differential diagnose, in my study, actually, I included only the unilateral piriformis syndrome. So approximately, there is a previous study stated that there is 40% of chronic lower back pain and sciatica cases seen in general practice may be caused by piriformis muscle. So there is misunderstanding or misdiagnosis for the piriformis muscle. Some people, they relate it is like because they're having low back pain. That's why they're having the pain radiating. Or sometimes they're saying the nerve root itself from the sciatic is compressed from there. So to screen that, I just did all the screening tests from the beginning to differential diagnose that the pain is not coming from the low back pain, or it's not coming from the root of the sciatic nerve compression. So why did I include in my study the unilateral piriformis syndrome? Because the muscle is coming from the sacral. When it gets shortening, it pulls. So shortening of the unilateral piriformis, it pulls the hip. It pulls the hip, and it causes lateral rotation of the hip. And automatically, it pulls the lumbar spine along. So there will be happening rotational dysfunction that's occurring on the lumbar spine. So due to the problem, the unilateral, because if there is bilateral piriformis syndrome, so both will be contracting. So the force will be generated equally. So the problem will be only on the hip. It's not on the lumbar spine. So I just took in my study the unilateral piriformis, because when it pulls the sacral, and it pulls the lumbar spine. So I did the differential diagnosis test that the patient will be in sitting position, the slump test. The patient will be seated comfortably, and the knee will be, hip will be flexed, knee extended, and the ankles dorsiflexed. And we ask the patient to bend forward. If the patient develops the symptoms, if there is radiating pain, then immediately we rule out that the pain is coming from the sciatic nerve. Yeah, because even the cervical thing, the slump test. So we ask the patient to do the movement. If he is having pain or developed any of the symptoms, that means clearly the pain is coming from the sciatic nerve. It's not piriformis syndrome. So I asked the patient to just bend forward and come straight. If the patient is still having the symptoms, that means the problem is commonly, basically, is the piriformis muscle tightness. There is no sciatic. The muscle is the one that is compressing on the sciatic nerve. It's not from the sciatic nerve itself. Okay? So we asked the patient to do the prime mover to screen that, and we rule out the problem is only coming from the piriformis muscle tightness. So the objective of this study was to determine the effect of Mulligan mobilization on reduction of pain and increased function in the patient with unilateral piriformis syndrome. Not only to know just to compare the both strategies, because the stretching technique is a straightforward, the preferred accurate choice of treatment for tight muscle. We just stretch the muscle, right? But I just focus on the dysfunction that's left because of the piriformis tightness. That is happening, the rotational dysfunction that is happening up there. So my method was 40 subjects was being collected randomly after screening, and I made sure that they only having the piriformis syndrome due to the piriformis muscle tightness. 40 patients was collected and divided into two groups. Group 1 is undergone the stretching of the muscle, the forward treatment for the piriformis syndrome. So the stretching was occurring due to the following. The patient was lying in supine in comfortable position, and then the knee of the involved limb was flexed. The hip and the knee both were flexed and crosses the contralateral side and placed firmly on the treatment table. And then the pressure was applied on the knee. And we kept this position for 30 to 40 seconds, and we repeated till the pain is reduced. And we asked till the symptoms of the patient is reduced. This is a direct treatment. Everyone is using this method to stretch the piriformis muscle. The second treatment that I used to compare, what I wanted to prove that the type of mobilization, Mulligan mobilization, when I apply it to the lumbosacral spine, it reduces the pain and increasing the function. So this is how I use the Mulligan belt itself. The patient will be facing away from the therapist. We palpate to check the problematic vertebra. After the checking, we stabilize from the above the problematic vertebra, and we ask the patient to go for the flexion and the extension. And repeating this so many times, we immediately notice, I repeated this like 10 times, and immediately I noticed the increase of range of motion. So my objectives, my measurement outcomes, or the scales that I use for this study, I use the VAS, Visual Analog Scale. It's a scale that's used subjectively to determine the level of the pain of the patient. It's from 0 to 10. 0 is where no pain, and 10 is the worst pain that the patient can tolerate. The other measurement tool I used was the lower limb functional index. Lower limb functional index is like 20 items, depending on how the patient will function. It's like he can walk in different surfaces. Is he able to take the stairs or not? Is he able to do all the physical activity or the activity of daily life? So after I compared the two groups, the first group undergone the stretching technique. The second group went for the Mulligan mobilization. And then I compared the result. And my result has shown that due to VAS scale, the group A, which undergone the stretching, has shown like noticeable reduction in the pain level. And group B, which undergone the Mulligan mobilization, also the pain level was reduced from 7 to 5.45. So it's like significantly different, and the pain reduction was significant. The other scale that I used was the lower limb functional index, or lower limb functional test. Group 1 was undergone the stretching technique. This shown like improving the functional mobility. The functional mobility of the trunk, the functional mobility of the lower limb, it's increased noticeably. And the second group also, in the according like Mulligan mobilization, they showed higher actually. They showed higher improvement in the functional mobility, and the range of motion is increased. So what I conclude is, even as the piriformis syndrome is caused by the tightness of the muscle, it's caused for the tightness of the muscle, the consequences of the lower back and the lumbar spine mobility can be improved by Mulligan mobilization as a single mode of intervention. So this is what I concluded from my study after I compared the two methods of stretching and Mulligan. Although Mulligan, it works only on the lower lumbar spine, but after the mobilization, the pain has reduced and the range of motion has increased, and the patient was able to gain the function that they have lost. And shukran. That's my mom.
Thank you, Samahir.